Assalamu alaikum. This is a lecture about brain tumors for the fourth year medical students at the Hashemite University, and it is part of the clinical neurosurgery rotation. In this lecture, we are hoping to cover the following topics: classification of brain tumors, clinical presentation of brain tumors, investigations, differential diagnosis of brain lesions, and lastly, we will be talking about the management of brain tumors.
As you may all know that we have brain tumors and spine tumors in the CNS, and we have peripheral nervous system tumors like neurofibromas and the schwannomas, but these are rare, and that's why we are not going to talk about it today. If we are speaking about the brain tumors, as you all know that there will be a primary and there will be secondary brain tumors, and the primary brain tumors can be intraaxial, that's to say within the spinal parenchyma, that is infiltrative, like the screen that you see on your left-hand side, that this is a tumor. This is first a T1 with contrast MRI scan, axial cut, showing a lesion, what we call usually a butterfly, because it is crossing the corpus callosum here in the middle part and causing this appearance on both sides. And this is very typical for what we call glioblastoma multiforme. On the left-hand side, we are looking into what we call extraaxial, and we will come to these definitions later. The extraaxial tumors are tumors that happen outside the brain tissue parenchyma, and this is usually from the coverings of the brain or the meninges. And a very typical example of these tumors is the meningioma. And you can see that these tumors are pushing the cortex of the brain rather than infiltrating the cortex. The other type of brain tumors is the secondary, and as you know, the typical example is the metastases, and usually these are multiple. They can happen within the brain parenchyma, that's to say they are intraaxial, or they can happen on the dura, and they are extraaxial or dural-based lesions. So as you all know that the brain tumors or any tumors needs to come out from one cell. So almost each tumor has a cell of origin. And this is typically a cell that happens in the primary tumors that happens on this histological tissue. So for the nervous tissue, we have histology of glial cells, which we can divide into oligodendrocyte, Schwann cells, microglial cells, ependymal cells, and astrocyte. The most common primary brain tumors are the astrocyte, which can result in astrocytomas, and it can be called gliomas. The other type of tumors is oligodendrocyte, which it is oligodendroglioma, which the precursor cell for these tumors is the oligodendrocyte. And then we have the ependymal cells, which is the lining of the ventricles and the central canal, and this is gank. Then we have the Schwann cells, which secrete the melanin around the nerve roots, and these can result on schwannomas. If we look at astrocytomas in general, and we said this is the most common primary brain tumor, we have 4 grades of tumor. Grade 1, and the very typical example of them is the pilocytic astrocytoma. And these usually are tumors of the childhood, and this is why the age is important. The older that we get, it's more likely that we get glioblastoma multiformes or grade 4 of astrocytomas, and it is less likely that we get a grade 1 or pilocytic astrocytomas, those ependymomas. About the grade 3 astrocytomas, which is basically the anaplastic astrocytoma, is the most common example out of these. Then we will move to speak about the most common astrocytoma, which is grade 4, and the typical example is the glioblastoma multiforme. These tumors are very aggressive, very ugly, and have a very bad prognosis. They are also very infiltrative to the brain parenchyma. They have a massive atypia, high mitotic numbers. When we say about mitotic, which means the rate of cell divisions of the tumor is high, which means that this tumor can grow up very quickly. The other thing that they do get necrosis, and basically the new vascularization is weak. The blood vessels and the blood supply is not enough for this mitotic activity of these tumors. So they tend to have necrosis. So why it is important to have these into grades? The reason why we grade these seed lesions is because they affect the prognosis and the treatment. For example, for grade 1, because it is a low proliferative potential and possibility of a cure is high, surgical resection is indicated once it is possible. Grade 2 lesions are infiltrative in nature and often recur even if we do total resection because of this infiltrative nature of these tumors. And thus, once we do surgery for them, we have to follow them very closely just in case they recur or they upgrade from grade 2 to grade 3 because they can transform to a higher grade. Grade 3 have a higher level of histological evidence of malignancy, like a nuclear atopia, mitotic activity, and that's why we have to resect as much as possible, as long as it is safe and will not affect the neurological function of these patients. And at the same time, we have to offer these patients radiotherapy or chemotherapy or both of them. The grade 4, which is the glioblastoma multiforme, it is a highly malignant tumor with a very high mitotic activity, and it is prone for necrosis. We try to achieve maximum resection when we do surgery for these patients, which is the aim of that is to reduce the tumor burden and give a better chance for chemotherapy and radiotherapy to work. So we spoke that there's a cell that is called astrocytes. Now we have the neurons, and the neurons itself can cause tumors. And a good example of these is the gangliocytoma and the central neurocytomas. Again, another cells, we have something we call the embryonal tumor. All our cells, the astrocytes, the neurons, come from a progenitor cells we call neuroectodermal or neuroepithelial tumors. And once there's a problem in this during the uterine life, so while the baby in their womb, mother wombs, we may have a problem with a tumor called medulloblastoma, which typically occurs in the fourth ventricle in the posterior fossa. The other thing that we have hematopoietic tissue, and this can also cause tumors, like a lymphocyte can proliferate and cause a lymphoma within the brain. And we have two types of lymphoma in the brain, either a primary central nervous system lymphoma, that's to say that the lymphoma itself starts within the brain tissue, or we have secondary lymphomas, which means that the involvement of the brain will become as part of systemic lymphoma that has spread to the brain. One of the risk factors for brain lymphoma is immunocompromised patients. So patients with HIV, patients in immunosuppressive treatment have a higher risk for developing lymphomas in the brain. Other tumors, the tumors that come from the mesenchyme, and for this, the typical and the most common primary benign tumor is the meningeal tumor, which originates from what we call the arachnoid cap cells. And the typical example is the meningioma, which comes from the coverings of the brain. And if we can see in the right-hand side, the tumor is isodense or slightly hyper-intense to the brain tissue. Then with contrast, it's usually vividly enhancing. It is not originating from the brain tissue, or rather it is causing compression on the brain tissue and the brain parenchyma. On the other hand, other tumors, hemangioblastomas and hemangiomas, and these typically occur in the posterior, the hemangioblastomas typically occur in the posterior fossa, and they have a cyst and intramural medule, which is usually vividly enhancing with contrast. So meningiomas, which is the most common primary benign brain tumor. So if we look at these are the possible locations of a tumor. Wherever there is a dura, there is a possibility that you will get a meningioma. So we know all that the dura covers the skull base. So we can get skull base meningiomas. They're like the ones on the right-hand side. They can be in the olfactory groove, in the suprasellar area, sphenoid, sphenoid, cavernous sinus, petroclival, CB angle, cerebellar cortex, and in the tentorium. Similar, we have the dura covering the vaults from the inside, and this can cause convexity, falcine, parasagittal, or intraventricular meningiomas. how we treat them, because these most of the time are benign grade 1 tumors. It depends on their symptoms. So if these are incidental, like for example, let's say somebody had a fall and he needed a CT scan, and we do the CT scan and we find incidentally a meningioma that would not explain why he had the fall or the collapse. We do short interval follow-up imaging, and we look at the rate of growth. If this is a tumor that is growing rapidly, we may consider a treatment. If there is no growth or symptoms, then why to bother? We just continue observing the tumor. The other possibility, if we do surgery, because this is asymptomatic in a patient, we have either one of two options. Either we do gross total resection or subtotal resection. So either we take this tumor completely out, and thus the risk of recurrence is low. So if you do total resection for a grade 1, the possibility of recurrence is about 8% only. And because of this, we just observe these patients and we observe these tumors. We don't do surgery or we don't do adjuvant therapy like whole brain radiation or stereotactic radiosurgery. We will talk about both options, the radiosurgery and the whole brain radiation later on. While if it is grade 2, most of the time, we will observe them, but we will make a shorter interval for screening. So instead of doing once yearly, maybe the first 2 years, we do every 6 months a follow-up, even if we do gross total resection. And sometimes some people do prefer to start adjuvant radiotherapy, even if there is a gross total resection. For grade 3, usually we have to follow up with a radiotherapy after resection. So that was how we classify all these tumors based on the histology. Either they can be astrocytes, and this is gives us the astrocytomas and the gliomas, ependymomas. They can be meningeal in origin or mesenchymal, and if they are meningeal, mesenchymal, they are meningiomas. If they are non-meningeal, they are hemangioblastomas. We can also have embryonal tumors like medulloblastomas. What about the location? Let's look at this. So again, we spoke briefly about the intraaxial and the extraaxial. So any tumor that is outside the brain tissue, we call it extraaxial. And any tumor that's inside the brain tissue, we call it intraaxial. So the tumors that comes from the astrocyte, we don't have astrocytes outside the brain. So these are intraaxial tumors, and we call them gliomas. Metastasis, ependymomas is another example for intraaxial tumors. Metastases also happen inside the brain, and this is why we call them intraaxial. They are within the brain tissue or the brain parenchyma. When we have tumors that is coming from the outside of the brain tissue and causing compression, we call them extraaxial. And this is very typical for meningiomas. And we have the dural-based metastases. One debatable issue is the colloid cyst and the tumors within the ventricle. We can get meningiomas inside the ventricle, colloid cyst, exophytic ependymomas, and exophytic gliomas. They can fill the ventricles, and it is debatable whether these should be considered intraaxial or extraaxial. Other way of classifying brain tumors is to say that these are supratentorial. And if you remember, the tent is the part of the dura that separates the supratentorial compartment, where there's the cerebral hemisphere, the corpus callosum, the deep basal nuclei, and it ends at the level of the midbrain or the tentorial incisura. Once we have a tumor in the supratentorial compartment, we can classify it according to the location. So if it is from the frontal bole back to the central sulcus, this is the frontal lobe, and this will be a tumor within the frontal lobe. If it is in the parietal lobe, which is extends from the central sulcus back to the calcarine sulcus, we call it parietal. Then we have the temporal, and the occipital lobe tumors. Other supratentorial tumors, these are extraaxial tumors. are the tumors within the cilia and the cilia turcica. And if you remember from your anatomy that the pituitary gland still sits in the cilia turcica, and we can get pituitary tumors, pituitary adenomas most commonly, rarely, very rarely pituitary carcinomas. And these can extend within the cilia, and so this is filling the cilia, and then it extends to the supracellular space. And you need to imagine how close the optic nerve, the carotid, and you can imagine that the chiasm will be around this area. How close is the optic chiasm to these tumors? And this is why most of these tumors may present with visual field defect or bitemporal hemianopia due to compression on the optic nerve. The pineal area, if you remember from your anatomy that we have the tegmentum and the septum of the midbrain, and below that, and there's the pineal gland towards the end of the corpus callosum and the beginning of the septal plate. And the pineal gland can cause sometimes some tumors like germ cell tumors, which is rare, and we see it in the childhood. And these tumors usually are radio sensitive, luckily, because it's a very difficult area to operate on. So these pineal tumors is another area we have a special differential diagnosis for pineal tumors. I'm not expecting you to know the differential diagnosis of pineal regional gland tumors, but I would like you to know that tumors in the pineal gland or the pineal region has specific considerations in a neurosurgery. Then we have again the infratentorial. So this is the tent. This is the hemisphere has been removed. So this is the folds of the dura, and it has been removed from the other side, so you can see the superior surface of the cerebellum. And we have the tentorial incisura around here, where the midbrain passes. And this is the corpus, the crus cerebri. And this is the aqueduct of Sylvius here, optic nerves, carotid arteries, cilia turcica with the pituitary inside it, and we have the basilar artery coming after union of two vertebral arteries. So anything below this level is called infratentorial. In the infratentorial space, we can have tumors within the cerebellar cortex, and this is a typical pilocytic astrocytoma with intramural nodule and a surrounding cyst within the cerebellar hemisphere. Another location is within the fourth ventricle, and this is how we see the fourth ventricle during surgery. It's a diamond-shaped structure. If the tumor is arising from the floor, as you know, the floor is lined by ependymal cells, and this will result in ependymomas. If it is coming from the superior surface or wall of the fourth ventricle, it is most likely to be a medulloblastoma because they arise from what we call the superior medullary velum. These are the inferior colliculi. And this is what we can see that this is tumor, which is an ependymoma, is completely filling and distorting the fourth ventricle. What else in the infratentorial? We have the extra-axial compartment, which is we call the CB angle or the cerebropontine angle. So it is the angle between the cerebellum, pons, and the vitreous bone. And this area is famous for having the fifth, the sixth, the seventh, the eighth, and all the lower cranial nerves. And the most common tumor that may arise in this area is a tumor coming from the acoustic or the eighth cranial nerve, and we call it, this is where around it is, we call it the acoustic schwannomas. The other differential for CB angle tumor other than acoustic schwannomas is epidermoid and epidermoid and arachnoid cyst. اوكي بريشر نرجع هذا للجروبين هلا مره ثانيه. احنا حكينا بس حبيت اوضح شويه كونسبتس لجروب A88 لانه ما اخذوش محاضره الاي سي بي. ممكن يزيد البرين تيشيو. ففي البدايه في عندي تيومر عم يكبر شوي شوي and this is causing increase in the intracranial pressure. بس برضه زي ما حكينا في محاضره الاي سي بي كل ما كان it is gradual and it is a slow increase in the intracranial pressure, there will be better compliance of the brain tissue and better compensatory mechanisms. But this patient may not present with signs and symptoms of increased intracranial pressure. Actually, this patient presented with personality changes due to compression on the surrounding brain tissue, which is the frontal lobe, which is responsible for cognitive and psychology of these patients. Brain edema, most of these tumors, especially the malignant ones and the meningiomas, are surrounded by edema. If you notice this is edema. This is the dark hypointensity on the T1 axial MRI scan. This is all edema. And if you look at the contrast, this is only the lesion. This is the lesion, and all the surrounding is edema. This increase in the edema will cause increase the extracellular fluid, will result into increased intracranial pressure. As we said, some of these tumors are prone to hemorrhage, like glioblastoma multiforme. Renal cell carcinoma metastases are very typical and notorious for hemorrhage. So if you look at this patient with this CT scan, this is a renal cell carcinoma that has bled inside, and this is acute deterioration of the level of consciousness of this patient because of the rapid increase of the intracranial pressure because of this hemorrhage. Lastly, the increase in the intracranial pressure can be due to hydrocephalus or hydrocephalus. We can see that this is a posterior fossa tumor that caused increase in the size. Well, it caused obstruction of the CSF flow. If you remember, the CSF flows from the lateral ventricle to the foramen of Monro, third ventricle, aqueduct of Sylvius, and the fourth ventricle. In this patient, the fourth ventricle is completely obstructed. So they will get temporal horn, which is part of the lateral horn, increase in size, and hydrocephalus, and these patients may become comatose, lots of headache. For a child, it is very unusual. They get a CT scan, and this is what we will see. Other symptoms, focal neurological deficit. And this can be due to direct compression. Sorry. So direct compression. So this is the central sulcus, and this is what we call the omega sign. Omega sign, which defines the motor cortex, which is behind the central sulcus. And we can see that this tumor is compressing the central sulcus on the right-hand side. So the patient is expected to have left-sided hemiparesis. Another example of compression causing neurological deficit is this pituitary tumor, which causing compression on the optic chiasm, and this will result in bitemporal hemianopia. The third is different because we have here, I don't know why this is going automatic now. Okay, this is a tumor which is just anterior to the motor cortex, but the edema is extending behind it to the to the motor cortex. And this patient presented with left-sided, with right-sided hemiparesis because of the edema. I'll put it again. So you can see that this is the edema here, but this is the only lesion. Once he was given steroids, hemiparesis improved even before we do surgery for resection of the tumor. One of the problems with these tumors, with the compression and the focal neurology, is what we call non-eloquent brain area, or the areas which will not cause a great loss of function. So these patients lesions in the frontal lobe are typical for this. The patient will have this lesion for years. They will have some personality changes, cognitive impairment. People will think they are getting older, or they are having psychiatrical problems. And at the end, they're actually having a frontal tumor that is compressing the frontal cortex, and that's why they are having all these neurological dysfunctions and personality changes. So it is direct compression, edema, hemorrhage, and rarely ischemia that can cause the focal neurological deficit. Endocrine symptoms. In the handout, you will find detailed endocrine symptoms. So we can have a prolactinoma, which is high level of prolactin. If this tumor is secreting prolactin, and this is usually present in females they present with galactorrhea, so they have milk secretions without being in a postpartum period. Even in males, they can have galactorrhea. Females will have abnormal menstrual dysfunction. For males, they will have erectile dysfunction and lower the sperm count and loss of sexual drive. If this tumor is secreting ACTH, you know that will present with Cushing syndrome, and I believe you all know the symptoms and features of Cushing syndrome. While if it is secreting growth hormones in children, it will cause giantism. In adults, it will cause acromegaly, and I do believe you have this in details in medicine rotation. Sometimes these are non-functioning. That's to say they are not secreting any hormones, but what will result is they are causing compression on the stalk, they cause compression on the optic chiasm, and they will present with such signs. The last thing is seizures, and this is usually generalized tonic seizures. Sometimes it is partial seizures, and the reason why these patients get seizure is direct compression on the nerve, and the neurons get damaged, and the gliosis. There's a theory about the change in the extracellular volume because of the compression, change in the electrolytes and the neurotransmitters, and local perfusion, that's say ischemia, hypoxia, and toxicity. And as you all know, the first a failure to control seizure can result in further seizures and secondary epileptogenic foci. Any lesion in the brain can be a tumor, but not every tumor or every lesion is a tumor. Other possibilities of lesions in the brain is a brain abscess. And if you look at the series on the top, we can see that there's a lesion in the on the left frontal hemisphere on the T2 with surrounding edema. Then we have a ring-enhancing lesion, which is usually very typical of glioblastoma multiforme or metastases. Okay, but when we do a special sequence on the MRI scan, which is called diffusion, we can see that this is restricting, which means it is hyper intense, and this is not similar to the CSF signal, which means this has a high protein content, and this is usually very typical of cerebral abscesses. So the first differential diagnosis of a glioblastoma multiforme or metastases is a brain abscess. If we look at this, very typical, very similar appearance on the right cerebral hemisphere, ring enhancement on the right cerebral hemisphere, but it is not restricting. After restriction, this turned out to be metastatic lung cancer. These two images are very similar also how the GBM will look. And this is why when we said that it is difficult to judge from radiology, that you need histopathology sometimes or biopsy to define these tumors. Again, cerebellar abscess, multiple sclerosis, large demyelinating lesions can mimic tumors. And that's why history is very important. If there's other lesions, it will go in favor with multiple sclerosis. If there's any suspicion, CSF studies are essential to rule out multiple sclerosis. Massive giant aneurysms in the basilar artery, it will look like a mass with different heterogeneities because of the thrombosis within the wall of the aneurysm, and this can be mistaken for tumor. The dilemma always is we have this all the time. We get these patients with basal ganglia hemorrhage, patients in their 60s, late 50s, uncontrolled hypertension, and they get the basal ganglia hemorrhage or intracerebral hemorrhage. And you can never tell that if this is a pure ICH or actually it is bleeding within a tumor. And what we do in these situations is that we do a follow-up MRI scan with contrast in 3 months, because if you do it immediately, you will not see evidence of tumor. All what you will see is the hemorrhage. So we do delayed MRI scanning on these patients looking for tumors. So how we would manage these patients? First, it depends how they present to us. If they present to you to the emergency room, they can present with different or 3 possible scenarios. The first one, which is very common, is seizures. And if they present with seizures, we have to follow the seizure protocol in our hospital. Whether they have a status epilepticus, you go with the ABC and then you start anti-epileptic, and you do all the work up necessary for seizures, which includes blood, for electrolyte, for blood glucose level, for screen for toxins if it is appropriate CT scan and with contrast or without contrast, depend on the protocol at your institution. If they come with hydrocephalus, it depends again if it is symptomatic hydrocephalus or asymptomatic. If it is asymptomatic hydrocephalus, patient with headache, nose with headache, vomiting, decreased level of consciousness, and papilledema, then you have to do a CSF diversion procedure like external ventricular drain or ventriculoperitoneal shunt or third ventriculostomy. If these patients present with a neurological deficit and increased ICD, and this is very important because this will affect the definitive treatment, okay? So we need to know whether this neurological deficit is due to the tumor itself and invasion of the tumor to the brain tissue, or it is secondary to the edema. And the way we can tell is by starting steroids and observe. If these patients' neurological deficit do improve with steroids, then it is not the direct invasion of the tumor or the compression effect of the tumor, it was the edema. And this may improve the patient's performance score, which we'll talk about shortly, and this will change our options for management. If patients with better performance scores, they are more likely to have surgery and they will have a better outcome from the surgery compared to patients with lower performance status. So the definitive treatment, how we arrange for it. So after we manage them in the emergency room, we get all the necessary images, we get the MRI scan with contrast, we get different sequences like FLAIR, if the patient or the lesion looks like a metastasis, we need to do a metastatic workup, which would include CT chest, abdomen, pelvis, tumor markers like prostate antigen, CEA. If it is appropriate, the patient may have upper and lower GI, looking for primary tumor, because about 20% of brain lesions can present as, of secondary tumors in the brain can present for the first time with a brain lesion. The second thing that we need is to have a multidisciplinary approach, which means it is not the neurosurgeon alone who can decide. It is a combined effort between the neurologist or neuro-oncologist, radiologist, radiotherapist, and decide patients should be individualized for the treatment depending on their age, comorbidities, and what is the likely prognosis for them. The third thing is the preoperative functional score or status, and this is, we will see the table in a second. It is assessment of how good is this patient functioning and caring about himself before the surgery. Because from multiple studies, we have found that patients with a better Karnofsky score have a better outcome after the surgery. So patients with low Karnofsky score or low performance score will not do good after surgery, and thus we try to avoid surgery for them. The other thing that we will tell us what to do or affect our judgment is the pathological diagnosis. If we think that this is most likely, let's say, an astrocytoma or a grade 4 GBM in a patient with a very bad functional status, and he's appropriate only for radiotherapy and chemotherapy, not for a major surgery, it may work, okay, having only biopsy. But if we are talking about somebody with a good performance status, no comorbidities, and he has also a GBM, but in the frontal lobe, which can be completely resected, this patient may undergo awake craniotomy, okay, to do a total resection. He may go a craniotomy with the aid of something we call 5-aminolevulinic acid, which will show the tumor during the surgery under ultraviolet light, so we can do total resection. There's intraoperative MRI scan also to improve the intraoperative to improve the resection amount of these tumors. So basically, the pathological diagnosis is the same in two patients. Both of them are GBMs. One of them has a good performance score, and the tumor is accessible surgically. The other one has a bad performance score, and the tumor is also accessible. So the one with a good Karnofsky score get an invasive surgery for total resection. The other one will end by having biopsy. Let's look at it from the different pathway. if a patient has anaplastic astrocytoma and the other one has a GBM, but they have the other levels, they have the same level of functional status, they have the same anatomical location of the tumor, the likelihood that the anaplastic astrocytoma will get a more aggressive treatment, because we know that he has a longer survival rate compared to the one with the GBM, okay? And he would have a better chances of survival. The other thing that the chemotherapy and radiotherapy will work better on an anaplastic astrocytoma compared to a glioblastoma multiforme. The last thing is the anatomical accessibility. If this patient have a lesion on the brain stem, and we know that resecting these lesions may cause a major neurological deficit, and this will make the functional status of this patient worse. And if it is worse, he may not get chemo or radiotherapy, then we are unlikely to offer him a resection surgery. It's most likely will be just a biopsy to confirm the diagnosis. And the reason we need to keep his functional status better so he can get chemotherapy and radiotherapy, because you cannot offer a patient with a bad performance status a chemotherapy and radiotherapy. Not because you don't want to offer it to him, but because he will not tolerate it. It will be torture to him for him to go 5 days a week to receive the radiotherapy and go through the complication of chemotherapy. So what is Karnofsky score? So this is the categories. It goes from 0 to 100, where 0 is dead, and 10 is moribund, where the patient is very sick and usually unawake. While between 80 and 100, the patient is able to carry normal activity with no special care needed, and it goes gradually between 70 until it is 20. The better the Karnofsky score before the surgery is, the better the outcome. So what we do for these patients, either we do biopsy, and the biopsy can be open, so we do a mini craniotomy and we open, or it is a stereotactic, and the stereotactic is either frame, so this is the frame. The patient will have a CT scan while this frame is fixed to his head. Then we make, or MRI scan, depending if you have MRI scan compatible frame, and then we will do our measurement, and this arch has multiple mesh measurement on it, and we will decide exactly where to open, and then we take the biopsy. There is the frameless biopsy, and it is using this type of needle, and this is star here. If you can see, this star has 4 circles on it. These circles are seen by an infrared camera, which will be connected with the previous images of the patient and will tell us exactly where to open and how much to go deep to take the biopsy. Then we have the resection option for these tumors, and it is either debulking, so we just reduce the size of the tumor, or we aim for total resection depending on the factors we've just discussed. We have conventional radiotherapy, and then we have the radiosurgery, which is this image here, where the patient is fixed in this frame, and there's 201 sources. Each one of these is called a source, and the beam of radiotherapy will go through each one of these. So at the end, we will have only one area of focus, which is the tumor area, okay? And by this, we avoid the side effects of radiotherapy, because each beam will pass through different pathway in the brain, okay? And then the focus point or the focal point will be at the site where the tumor is.